Welcome to the EKG Guy. If this is your first time, I'm glad you're joining us, and welcome back if you're returning. So we've been going through this EKG coding reference guide that is available online, and what many of you have asked for was to combine the different sections of this into one part. And so what I thought would be helpful, and the reason behind that, so you didn't have to go through all the videos separately, what I'm going to do here is combine the AV conduction delays, so the AV blocks. Okay, so part 3, this is one that many of you have asked for, so I'll combine them all. So you'll look at first degree AV block, you'll look at second degree AV block, Mobitz type 1 or Winky block, and type 2, and you'll look at third degree AV block in this lecture. Okay, now if you don't have access to the reference guide, all you have to do is put this link in here, okay, and then you'll enter your email, click submit, you'll get an email, okay, and from your email there will be a link just to confirm it, and then you'll have access. Okay, and that's just the first time. Otherwise, if you're returning, you can have that all available. All right, and then the reference guide here, you can go click down this drop down menu, you can follow along. Okay, so in this lecture we'll look at the different types of AV blocks, we'll look at examples, why they occur, okay, and hopefully get you up to speed on and just a refresher on all these topics. And you can find some of those examples on the reference guide, okay, and you can always have that to access on the go. If you're interested in some of these other things that we've gone through, the part 1, the general features, rhythms, different types of rhythms, voltage, access, how to find access, that's sometimes an issue, bundle branch blocks, myocardial infarction, localizing if it's acute or chronic, different clinical disorders, ST abnormalities, and so forth. Okay, so you can go and listen to those lectures as well. Now, if you're more interested in the course that we offer, you can go to www.ekg.md. Okay, click on the EKG course, and what this entails, and this is what we use here at Mayo Clinic to teach. It's used as a primary resource with training our techs. The medical students just used it, and I'll share some of that feedback, but suffice to say that it was considered exceedingly better than in the most comprehensive course that they've taken. All right, so I will leave that for another lecture, but you can check that out. The one thing I get asked is, are the YouTube videos different from the ones in the course? And that is absolutely yes. And how it differs is the course is more comprehensive, much more detailed into pathophysiology, making sure you understand everything. Okay, understanding why you see what you see on the EKG, that's the goal, and hopefully that accomplishes it. Something new we're launching are questions, so there'll be over 600 or so questions with every lecture, with the book material, with your calipers, so you'll have everything to go there. Okay, so stay tuned for that. Well, let's start a review of the AV blocks, and I'll see you in the next lecture. So first degree AV block, what's going on here? Well, this is a minor AV conduction defect. This is a partial block at or below the AV node. So if we review our conduction system, here's our box diagram of our heart. This is the right atrium, this is the left atrium, the right ventricle, and the left ventricle. Okay, we have now our conduction system. If we place it here, this would be our sinus node up near our superior vena cava. Here's our SVC. This is the sinus node where normal conduction starts. Okay, from the sinus node, we have our AV node. Okay, and these are internodal pathways that connect the two. We have a Bachmann bundle to the left atrium. We have a His bundle. We have the right bundle branch. We have the left bundle branch. And if you recall, the left bundle branch has two fascicles, a left anterior fascicle and a left posterior fascicle. Okay, so and then from there, that's how the conduction system, so from atria to ventricles. Okay, so when we talk about conduction delays, we're focusing here on this AV node, and we're saying that there is a partial block at or below the AV node, so maybe above or below it. Okay, that's going on here. And what's happening in this case is we still always have a P wave that precedes the QRS complex at a fixed but prolonged PR interval. Okay, so atrial activation is transmitted to the ventricles with a constant delay. That is key here, and that's what we're seeing. The normal PR interval, so normal PR interval should be less than 200 milliseconds, okay? So once you hit 200 or you go above 200 milliseconds, we consider that a first degree AV block if it's constant. And the key thing here is constant prolongation, okay? So what is that PR interval? Remember, if we draw this out, this is our P wave, this is our QRS complex, and our T wave. From beginning of the P wave to beginning of our QRS complex is our PR interval. Don't get that confused with the PR segment, which comes after the P wave and then before that. So that's our PR segment. But we're focusing on this interval, and that being prolonged, but constantly prolonged. So if you envision, maybe you have a PR interval of about 220 milliseconds, but it's always that 220 milliseconds, meaning you have a P wave, PR interval, QRS complex, but always that interval from beginning of the P wave to beginning of the QRS complex is always that 200 milliseconds or 220 milliseconds, constantly that size or that duration. Okay, again, each P wave is always followed by a QRS complex. You don't have any dropped beats, as we'll see with the upcoming AV blocks. Those have drop beats, okay, and in this case, there is always a correlation of the P waves to the QRS complex. We'll see in third degree AV block or complete heart block that the P waves are pretty much marching out on their own. In this case, the P waves are always associated with the QRS complex. And notice here, one of the easiest ways to do it is find a P wave that starts on one of these thick lines like this one, and notice that it goes beyond this next thick line. And why that's important is from one of the thick lines to the next is 200 milliseconds. So if you see it beyond that, you know that it is a first degree AV block, okay, or at least it's prolonged. And if you see that consistently throughout, so notice that these PR intervals are constantly prolonged. And you always want to look at the beginning of the P wave to the beginning of our QRS complex. The best leads that I find the most helpful are looking at the rhythm strips V2 and V1, okay? You don't want to look this way because some leads you may not even see a P wave, okay? In lead AVL, for instance, maybe there's the P wave there, but they're sometimes hard to see. So focus on one lead and look across. Make sure there's no drop beats, okay? Notice there's always a P wave associated with the QRS complex. This is a T wave at the end of each one, okay? So remember, prolonged PR interval represents delay from the onset of atrial conduction to ventricular conduction. It does not evaluate the sinoatrial node to the atrial tissue. Okay, we saw that with the previous sinus exit blocks or arrest that we saw earlier. Okay, where it's those transitional or pacemaking cells that are causing that issue. In this case, we have that prolonged PR interval, and everything below. Okay, once conduction gets through this almost stop sign, you can consider it, but it doesn't completely stop, all right, and everything below it continues as it normally would. So notice that the QRS complex will always be the same, okay, throughout. So what is causing this? Well, this could actually be a normal variant. In athletes, if they have an increase in vagal tone, this can cause it as it acts on that AV node to slow the conduction. All right, you can have it from an inferior MI or heart attack involving the inferior portion because the right coronary artery tends to supply that inferior portion, and if you have that blocked, okay, the right coronary artery also supplies the AV node. All right, so if you maybe have a proximal right coronary artery occlusion, it may cause some of these conduction delays at the AV node. Okay, mitral valve surgery, if you're actually interfering with that AV node. Myocarditis, such as Lyme disease, causes these AV blocks, and it tends to affect the AV node. If you have a high level of potassium, so hyperkalemia, and then AV nodal blocking agents. So medications that we actually give our patients can cause this. Beta blockers, calcium channel blockers, digoxin, amiodarone, all these can cause this. Now, what is the clinical significance? Well, this often does not cause hemodynamic instability, and there's no specific treatment required for this, okay? No need for pacemaker, as we'll see with different types of blocks we would actually require, but in this case, it's quite well tolerated. You always have a P wave followed by a QRS complex, so there's always a atrial contraction and ventricular contraction, and no issues there. So again, the key points here is that you have a constantly prolonged PR interval. It's not getting longer, it's always constantly prolonged. In this case, it was, as you can see, quite prolonged. I believe it was 264 milliseconds by the machine. So again, above that 200 milliseconds, you always have a P wave that's followed by a QRS complex. All right. So again, minor AV conduction defect, partial block at or below the AV node. P waves always precede QRS complex, but a fixed prolonged PR interval. You always have atrial activation transmitted to the ventricles, but a constant delay in that. All right. Clinically, does not tend to cause any hemodynamic instability, and there's no specific treatment required for this. Well, that's the end of this lecture. I hope you learned something. So second degree AV block Mobitz type 1. What is going on here? So it's also known as Winky block, you may have heard it, and this is where we have progressive PR interval lengthening with intermittent dropped beats. So with the first degree AV block, we saw no dropped beats. We saw constant prolonged PR interval, no drop beats. Here we're starting to see drop beats, and what we're saying is that the PR interval, remember, just to review, this is our P wave, our QRS complex, and our T wave. The PR interval is from the beginning of our P wave to the next one, okay? And this is our PR interval. And what we're saying is that PR interval is slowly getting longer. So if you imagine the first PR interval is that, the next PR interval is this, okay? The one that follows it maybe looks like this, and then eventually there's no beat that follows it. Okay, and then the next beat that comes after is back to our first beat. Okay, so notice that the PR interval lengthens. This is the baseline. It gets longer, longer, longer. Okay, and it drops there. All right. Now it doesn't always have to follow that pattern, but one clue that you could tell that this is Mobitz type 1 is if you look where there was expected to be a beat. Okay, so we expected one here. Look at the beat that would be after it, which we would say would be this one. Okay, and notice that the PR interval here is shorter than the one that precedes the drop beat, which would be this one here. Okay, so notice that this PR interval after it is shorter than the one that precedes the drop beat. Okay, that's a clue to tell you that this is Mobitz type 1. Now, one way people remember it, when I was initially learning it, was longer, longer, longer drop. That's a sign of Winky block, okay, or second degree AV type 1. Now, so what's going on is what's getting longer is that PR interval slowly gets longer, and then you have a dropped beat, and that's Winky block, okay. Now, you don't always have to have 3 PR intervals that get longer. It could be longer, longer, and drop, but that's just one way to remember it. Okay, so this is a reversible conduction block that occurs at the AV nodal crest or the atria-AV nodal junction. Okay, so what you can imagine, and if we draw our heart out here, so this is our box diagram, our right atrium, right ventricle, and left ventricle. And then we have our conduction system, our sinus node up here, our intranodal pathways to our AV node. So this is our AV node. This is our sinus node. We may have a Bachmann bundle coming to the left atrium. We have a His bundle, a right bundle branch here, a left bundle branch that subdivides into our anterior and posterior fascicle, left anterior and a left posterior fascicle. Okay, and what we're saying is that you have slow conduction, or you may have a initial normal conduction. Okay, so conduction flows normally, but then maybe afterwards, the next one, you have maybe a small block. Okay, and that's what lengthens the PR interval. And then the next beat that comes, maybe there's even a bigger block, so maybe even a thicker line. Okay, and that's prolonging the interval. And when the next beat may have an even longer block that almost makes it complete, and that's why no beat can get through, and that's why it's dropped, okay? And so pretty much no ventricular depolarization occurs here, okay? So this is malfunctioning of AV nodal cells. They progressively fatigue, you can think of it, until they finally fail to conduct an impulse, okay? And this can be from an injured AV node with long refractory period, okay? Eventually just gets tired out and just does not conduct through, and that's why we have that drop beat. But eventually, because there was so much time during this time, okay, it's ready for the next beat, and that's why it goes back to that short PR interval. Now, what causes this? You can have an increase in vagal tone, so athletes may see this, an inferior MI. So remember, the RCA, the right coronary artery, tends to supply the inferior portion of the heart, and the RCA also tends to supply that AV node, okay? So sometimes if you damage that or have an occlusion there, this may result in it. Myocarditis, Lyme disease, tends to have impact that AV node, and you may see progressive different AV blocks. Mitral valve repair, okay, it can actually damage this. Medications can affect the AV node, so beta blockers, calcium channel blockers, digoxin, amiodarone, and so forth. So what is the clinical significance? Well, this is often benign, and there may be minimal hemodynamic instability, but this tends to be a low risk of progressing to third degree or complete heart block, okay? So if patients are asymptomatic, we tend to, not treat them. Okay, no treatment is generally required for them. If they're symptomatic, rarely do we have to, require permanent pacing, but that's sometimes I think we do, or atropine may work. Okay, so let's look at this example here just to ensure we know what we're seeing. So notice that we have, these are P waves, okay? And then there's a drop B. So let's start right here, okay? Starting right here. Notice you have this P wave here, okay, with that PR interval. So again, I'll just erase that. So notice this PR interval. Notice the one after it gets longer. This one gets even longer. And then you have this P wave and a dropped beat. Okay, but notice what follows it. This PR interval here is shorter than this one here. Okay, and that is a clue that you're dealing with this second degree AV block Mobitz type 1. Okay, so again, here's that longer, dropped B is a sign of Wenckebach, okay? And again, what follows this, here's that PR interval, almost like back to baseline. Then it gets longer again, and then in this case, you have a drop B, okay? So it fatigues even earlier, so you don't always have to have it. You can have it look like there is these grouped beats because you pretty much have a few beats in a row and then a drop beat, so maybe these look like they're grouped together, okay? Or even these, and then you have the ones that follow. These ones look like they're grouped together and so forth. So that's what we mean by this grouped beating, okay? So hopefully that makes sense. These are the main things. So you have progressive PR interval lengthening with intermittent dropped beats. Remember to look after the drop beat and before it, okay? So again, we said our dropped beat occurred here. So look at the PR interval after it, which would be this one, and notice that it's shorter than the one that precedes it, okay? And that's a clue that you're dealing with this. Again, it tends to be reversible conduction block at that AV nodal crest or the atrial AV junction, okay? You have progressive fatiguing of these AV nodal cells and malfunctioning until they fail to conduct an impulse, and that's where that drop beat comes about, okay? Again, the clinical significance, this is often benign with often minimal hemodynamic instability. There's a lower risk of progressing to third degree or complete heart block. We'll see with Mobitz type 2 that there's a greater risk, and that tends to be something that we want to manage more earlier on, okay? So again, most patients, it's typically benign, but we can see this. So again, progressive prolongation of the PR interval until a P wave is blocked and there's no conduction to the ventricles, therefore no QRS complex that you see. All right. Remember, longer drop, that's a sign of Wenckebach. Well, that's the end of this lecture. I hope you learned something. So second degree AV block Mobitz type 2. So we've looked at type 1, all right, and we saw just to review these, so the AV blocks and to see where we're at, the first degree, we had constant prolonged PR interval, so increase in that PR interval, and we had no dropped beats. Now we have second degree AV block, and we looked at 1, 2, and then eventually we'll look at third degree or complete heart block, okay, but we won't do that here. Now in second degree type 1, okay, we had increase of the PR interval that was progressively increasing. So progressive increase in the PR interval until you had a dropped beat, and that pattern would then repeat itself. Okay, so increase, remember longer drop, that's a sign of Wenckebach, that's type 1. Now in type 2, what we'll look at here is we have a constant PR interval, and then we have a non-conducted beat or intermittent dropped beat. Okay, so again, Mobitz type 1, we had increase until the AV node fatigued enough that it could not conduct, and then we had a drop beat. In this case, we just have conduction that is normal, and then all of a sudden you have a dropped beat. Okay, so let's take a look at this. All right, so in this case, you have intermittent dropped QRS complexes and non-conducted P waves without a prior PR interval lengthening, as we saw in type 1 of the second degree AV blocks. So normal constant PR interval when it's conducted. So if you look at this EKG, look here, you'll see this P wave and this. Remember that if we have a biphasic P wave like that, okay, here's our QRS complex, and we may see that in V1. These biphasic P waves, they are normal. Okay, now, so here's your P wave. Your PR intervals from the beginning of our P wave to this portion, and we're saying that this is constant, there's no prolongation, and then there's a conducted QRS complex. So PR intervals normal, conducted complex, PR intervals normal, conducted complex. P wave here, no conducted complex, and then it goes back to its normal PR interval with a conducted. Then all of a sudden you have a P wave, non-conducted beat. Okay, then you have a P wave that's with a normal PR interval, conducted beat. P wave here with a normal PR interval, conducted beat. P wave, no conducted beat. So notice that you have just a P wave and then there's no beat. Okay, but every time you do have a beat, you have a P wave with a normal PR interval. So there's no prolongation of that, as we saw with the previous one. Now if it is prolonged, it'd be constantly prolonged. So that's the main thing, that it's a constant PR interval, and then you have these intermittent dropped beats as we see here. So that's this one here. Now what we have in this case is conduction failure at the His-Purkinje system, so below the AV node. So if you take a look, let's just erase some of this here. In our conduction system, it's always good to review that here. So we use our box diagram to simplify it. Here's our right atrium, our left atrium, right ventricle and left ventricle. Conduction system starting up here with our sinus node. We have these internodal pathways that come to this AV node. Okay, so this is the AV node. We have a Bachmann bundle that comes to the left atrium. We have the His bundle subdivides into a right bundle branch. We have a left bundle branch. Remember, it has two fascicles, a left anterior and posterior fascicle, anterior and left posterior fascicle. Okay, and that's why you probably heard of left posterior fascicular blocks or left anterior fascicular blocks. That's because of those are individually blocked. So let's look here. So we have conduction from the sinus node coming down to the ventricles, and what we're saying here is happening is that you have this conduction failure at the His-Purkinje system. So pretty much below the AV node, somewhere down here, where you may have some conduction failure, okay? And that's what's going on. There's pretty much a block below that AV node that's causing failure of conduction. So you have intermittent dropped beats. You may have a P wave, because there's atrial depolarization, but then it cannot get through. So the P waves form, it doesn't get through, so you have no QRS complex, and that's what we're seeing. A P wave here, no complex. P wave, no complex. Okay, same thing here, and so forth. All right, and notice that there's no change. The big thing that's different from first degree is that there are dropped beats. Remember, in first degree, there are no drop beats. Okay, so second degree and onwards, we can have some drop beats, especially here. Okay, these two. So again, differentiate them. Constant increase in PR interval and no drop beats is first degree AV block. Second degree, Mobitz type 1 or Winky block is when you have progressive lengthening of the PR interval and a drop beat. Constant PR intervals and then drop beats is Mobitz type 2, which we're seeing here. All right. Now, causes can be from an anterior heart attack, MI, idiopathic conduction system fibrosis, mitral valve repair, myocarditis, Lyme disease, rheumatic heart disease, many causes, amyloid, lupus, sarcoid. Hyperkalemia may result in this. Medications that slow conduction at the AV nodes, such as beta blockers, digoxin, calcium channel blockers, amiodarone can do this. Now, the clinical significance, well, these patients actually are at risk of hemodynamic compromise. Unlike where we saw with Mobitz type 1, less often, these patients are at a greater risk. Okay, they're at risk of severe bradycardia and progressing to complete AV block, and that's why these patients often get a pacemaker placed. So the main thing you want to notice here is this point here: constant PR interval with all the conducted beats. All right. So hopefully that makes sense, and hopefully you are able to differentiate between these blocks. All right. And in the next one, we'll take a look at complete or third degree heart block. Well, that's the end of this lecture. I hope you learned something. So third degree AV block or complete heart block. This is where you have complete absence of AV nodal conduction. In other words, there's no supraventricular impulses conducted to the ventricles. And because of that, there's no relationship between the P waves and the QRS complexes, and that's why we get something called AV dissociation. Okay. So you may have heard this, in which the P waves will pretty much march out on their own, and the same with the QRS complexes. So they're almost going at their own rate and not really related to each other. So what's going on in the heart? Well, if we draw our box diagram here, our right atrium, right ventricle, and left ventricle. Then we have our sinus node up here near in the right atrium, near our superior vena cava. We have these internodal pathways to our AV node here, the His bundle, a right bundle branch, a left bundle branch that has those two fascicles, the left anterior fascicle and the left posterior fascicle. Okay, so that's kind of the conduction system. You also have a Bachmann bundle to the left atrium. All right, so what's going on here? Well, these are all AV blocks, so they're actually happening within that AV junctional region. Okay, there's blockage from conduction from the atria to the ventricles. Now you can have a very big complete block here where nothing is getting through, so the impulse starts from the sinus node or somewhere in the atria and then meets that almost a halt because it can't get through. Okay, or you may have a block down here that does not let anything to get through beyond that, so maybe it gets through the AV node, comes down here, and then hits this almost like a stop sign. It won't go any further. Okay, and as a result, you have separation of the P waves from the atria and the QRS complexes in the ventricles. So the P waves or the atrial impulse will come down, meet a halt or stop, okay, and will show that and then repeat itself. So have its own rhythm, okay, thinking that it's getting through, but it's not. And because the ventricles are not getting any signal, they'll start their own impulse, okay, and maybe that starts from somewhere along here, okay, if the block's a little higher, okay, or maybe it starts somewhere in the ventricles and you have maybe a ventricular escape rhythm that takes over. All right, because the ventricles need to conduct and they're using their safety net to kind of keep everything going. All right, and this is what we think of third degree block. This is complete heart block, okay, and this is the end of second degree AV block Mobitz type 1 and 2. So if things progress so far, this is what you can get. All right, so obviously this is quite important. And this is conduction failure above Mobitz type 1 or below Mobitz type 2 AV nodal blocks. Okay, so what can cause this? Well, you can have an inferior or anterior MI, It can be idiopathic conduction system fibrosis. So over time, as people get older, the conduction system gets older as well, and it starts to fibrose. It can be from Lyme disease. Okay, so Lyme disease tends to have an effect on that AV node. So if this AV node continues and patients are not treated for Lyme disease, it can progress to the third degree or complete heart block. Okay, and obviously treatment of Lyme disease actually helps and potentially can reverse this cause and as it starts to heal. Now medications obviously that affect that AV node can cause this, so you have to be cautious. Often not significantly this much, but some to be aware of. You have your beta blockers, you have your calcium channel blockers, digoxin, okay, things that are slowing down that AV nodal conduction, and amiodarone can do so as well. Now clinically, these patients are really at high risk for hemodynamic compromise. Okay, they're at risk for ventricular tachycardia, standstill, and sudden cardiac death. So they need a pacemaker. Okay, so these patients are important to be aware of, and these patients typically and almost always need a pacemaker, at least a temporary pacemaker if things, for instance in Lyme disease, as things get better. So again, let's just review what's going on here. So we said there's complete block pretty much of somewhere in the conduction system, which is not allowing the atrial impulses to pass through to the AV node, okay, to stimulate ventricular activity. So there's complete failure of that. All right, we saw the blocks, and as a result, we said that the P waves will pretty much go at their own rate. And if you look down here, you may be like, well, there are no P waves. Okay, maybe this is an escape rhythm. Well, there are actually, and that's why you have to look at the other leads. Okay, even in lead 2, you may be able to see these P waves. Okay, but the best one is V1. All right, V1, you can certainly make out the P waves here. So notice here's a P wave, here's another one. Okay, and notice that these P waves are going at their own rate. See, that one's buried in the QRS complex, and there's another one, and here's one here. Okay, so those are all P waves going at their same rate. Notice that if I were to erase this, you can see that those PR intervals are not the same. Okay, so you may say, oh, this P wave is associated with that, but notice that it's different than these that follow, to the point that it really doesn't exist in these ones. Okay, so these P waves are not related to the QRS complex. They're pretty much going at their own rate. So you have the sinus node firing. Okay, so you may have a normal sinus rhythm because you have this rhythm firing, although you're not conducting through. So the P waves are contributing to the normal sinus rhythm. Okay, but in fact, you have a separate rhythm coming from the ventricles, and that's this one here. So notice these narrow complexes that are going by themselves. Okay, notice they're narrow, so likely not coming from the ventricles, but somewhere maybe from the conduction system, as we mentioned here. And that's what we would call a junctional escape rhythm. So what you have here is a normal sinus rhythm with complete heart block, or AV block, third degree AV block, with a junctional escape rhythm. Okay, so that's pretty much what's going on in this EKG. Now this stuff here is all artifact. You'll notice that. Okay, that's artifact that's noted in those precordial leads, not in fact ventricular fibrillation, because notice everything down here is below, above, and below. So that's important to note. All right, so this is, hopefully that's making sense. Okay, you have two separate rhythms pretty much. You have a normal sinus rhythm and a junctional escape rhythm because of this complete heart block. All right, so you'll have a constant P to P interval, so those P waves that we notice, and constant R to R intervals. So these intervals tend to be constant. Okay, and as we mentioned with the P waves, which are these ones here, if you were to measure out these P to P intervals, they would be constant as well because it's a separate rhythm. Okay, and the atrial and ventricular rhythms are independent of each other. The atrial rate tends to be faster than the ventricular rate, as the ventricular rate is driven by either a junctional rhythm, as we saw here, a ventricular escape complex, or a ventricular pacemaker. Now, we mentioned a number of associated conditions that are listed here that you can review. But the main things that you need to know is, again, this is complete absence of AV nodal conduction because no supraventricular or ventricle or impulses above the ventricles are conducted to the ventricles. There's pretty much that big halt here that we said that is just not allowing the impulse to go through. And that's why you have separation of the P waves and the QRS complexes, and they may in fact be different rhythms that are coexisting. And that's what we call AV dissociation. This is the endpoint of all AV blocks. Okay, we talked about first degree, second degree, Mobitz 1 and 2. This is the end of it, third degree or complete heart block. Okay, number of different causes, and remember, clinically these patients are at high risk of hemodynamic compromise. Okay, and oftentimes need a permanent pacemaker unless it's a reversible condition. Well, that's the end of this lecture. I hope you learned something. Now, just to keep you in mind of our course material that we have available. So again, if you go to our website, www.ekg.md, okay, so this is our website, and what you'll notice is that if you go to the EKG course here, okay, you'll find stuff that's separate. So notice that we have a number of topics, practice material, lectures, a way for you to contribute, and this is the course here over here. So you'll notice we have over 300 videos or so, and that's more on YouTube. There's another 100, more than 100, about 200 videos that are available with the course. So those are separate videos, and this course is really designed to take you from a beginner to advanced interpreter. Okay, so completely separate from what you're getting online for free. Okay, these are course material that comes with it. So notice that you have a book. Okay, and then you also have the pocket guide available, so you can choose which format. They are the same thing, both these book and the pocket guide, different formats. I really like this small one because you can keep it in your white coat if you're in the clinic or in your pocket, and it's really available on the go. Now with the book, you also get videos. So notice these are the videos, okay? And these are a video for every single page in that book. So it's over 30 hours of video. Now there's a number of practice material that I continue to upload there. Okay, we'll have practice questions coming soon. So all of that's available. Again, this is separate from all the free material that you get already. Okay, so this is more high yield stuff. This is what we used to teach our technicians here and our students here at Mayo Clinic. And it's used now among many institutions. So check that out. Now, what it also includes are calipers. So yes, you get calipers with this course. Okay. I don't know anyone else that offers that, but you do get calipers. I think they're very helpful, and they can, if you know how to use them correctly, can help to identify different arrhythmias that are going on. Okay. And then you also get our pocket EKG reference. Okay, this was something we've put together as we were developing course for the fellows, and this is really nice. It has every code, as you saw earlier, laid out there. Very small pocket guide available. I had help with my colleague, Dr. Peter Noseworthy, who's the head of the EKG lab here at Mayo Clinic, in editing it. So this is something that we use, and we've found very helpful. So go to the EKG course. You'll see examples of lectures, okay, why we developed this, okay. A lot of it came about from myself struggling with learning EKGs, having a father that was an interventional cardiologist and, still struggling. So my struggle is a struggle that I don't want you to have in learning them, okay. You can read all those introductory books, but honestly, they are not enough, okay, and you find yourself using other resources, which is part of the learning process. I wanted to expedite that process for you and make it less inefficient in pretty much what I struggled with going and learning through EKG. So again, from beginner to advanced level with this course, you get the book, the calipers, the coding reference, video access, okay, and now we're offering 25% off. 25% off. Put that code in on checkout, and you'll have yourself 25% off. That will it's pretty much covers the cost of what we use to print the material. So We don't really make much off it. It's more to help our learners grow and really be able to contribute to patient care. That's why we do this, and we love doing it. So thank you so much for your support. If you have any questions, just leave them below, and we're happy to answer them. All right, have a great day.